Can I start now?
Go.
Can I start?
You okay, Jacob?
Okay. Welcome everybody to this poster session on guidelines with and for users. I like this this session because it's virtual. It's completely different when we have a physical meeting, but this session is very interesting because all the posters presenters will also present, and there's time for questions. We have 12 posters that will be presented. I hope everybody will be there. And anyhow, we can improvise if people are not there. But I'm very interested in your talks and in your poster. What I've seen is that most of the posters are from totally different countries, from different continents, different speakers, but the topic is the same on guidelines with users and for users. Guidelines can be developed in ivory towers, but should be used in clinical practice. So we are very interested in what happened in your country, in your context, on the use of guidelines. Now I stop with introducing this session and give the floor to Trudy Beckering from Belgium with a poster on closing schools for COVID-19. Trudy, it's yours.
Thank you very much, Jaco. I will share my screen. And here's my poster. So welcome. My name is Trudy Beckering, and I work as a guideline methodologist at the Primary Care Rapid Recommendations Group based in Belgium. In September last year, our government faced a tough decision. The COVID infections rates were rising, and every day children attended schools, possibly firing up the infections. Would closing schools be a good way of managing this rise? Therefore, we systematically evaluated the benefits and harms of closing schools. We compiled a panel of 22 people consisting of pupils, teachers, parents, school managers, clinicians, and researchers. And with this panel, we assessed which outcomes are important. And these outcomes are listed on this poster. For each outcome, we searched for reliable data from Belgium, and the certainty of evidence was rated using the GRADE method. Our evidence showed that comparing the situation when schools were closed compared to the situation when schools were open, that when schools were closed, there were fewer infections, fewer hospitalizations, and fewer mortality. However, the certainty of this evidence was very low. This means that we are uncertain that a lower number of infections, hospitalization, and mortality can be attributed to closing the schools. Furthermore, we found that closing schools increased a learning delay, and we were moderately certain about this delay happening due to schools being closed. Finally, closing schools increased mental distress in children. We saw more anxiety and more depression, and the certainty of this evidence was low. For all other outcomes, infection risk, long-term learning delay, mental distress in children and parents, we did not find any evidence. We had 2 online meetings where we discussed these evidence summaries. We discussed the preferences of children, teachers, the parents, and acceptability of the recommendation if we would recommend to close schools. We found that we had to incorporate the infection levels in our recommendation, and we also found that we were more certain of harms of closing schools than of benefits. We therefore recommended schools to stay open as long as possible. However, the strength of recommendation was based on infection levels in the local environment. In summary, we're using stringent methods, methods, we succeeded to make a rapid recommendation on this delicate topic affecting a high number of stakeholders. We did so transparently reporting the underlying arguments. Thank you for your attention.
Thank you very much, Trudy. I'm looking whether there are questions, and I do not see now, but I can first try to ask you to clarify the figure, because the upper recommendation is strong and the down recommendation is weak. So that's correct, yeah?
Yes, we decided that that we had to make a distinction in situations where the infection levels were high, when the epidemic was very active, compared to periods where the epidemic was not so active. And if there were a lot of infections in schools, the stakeholders said, well, it's rarely impossible to keep schools open because children are at home, teachers are at home, and therefore in that situation we made it into a weak recommendation. Which means that if possible, we would recommend to keep it open, but in some circumstances it would be okay to close the schools.
Yeah. So, well, in the figure you see that the greens for the first recommendation is strong, and the green filled in the second recommendation was weak.
Yeah. So yeah.
Exactly. So it's not the bold line, but it's whether the arrow is filled.
Is filled. Yes, exactly. So this is a strong recommendation, and this is the weak.
It's a weak recommendation.
Yeah. Yeah. Thank you.
Okay. My second, my other point is truly you made this rapid recommendation, but to how much extent did it influence the policymakers and your government?
Well, our question was not, our project was not done on request of the government. Our aim was to try whether the method of rapid recommendations could be used in this topic. However, we did it last year, and we started it in September, and we were able to finish it before our government made the final decisions. And we were able to present our rapid recommendations to the government, and they were very pleased because we gave a nice summary of all different factors that influence the decision. And of course, government needs to make a choice, but it's important that they make clear why they make a decision and what are the consequences.
Yeah. We could have used this also for the Netherlands and maybe for other countries.
Really, yeah.
I have a question from a colleague from you in Belgium. Lene Koning is asking, oh, my question is answered. Her question was, the infection rate in primary schools is increasing again in Belgium. Do you know if the government takes this research into account? So you already answered this question. Thank you, Lane, also for asking this question. Are there other questions from the audience? And maybe we could come back on this after all the presentations, because this is a very interesting issue. Okay. And if it is not the case, I would like to give the floor to the second speaker. I would like to introduce Kimberly Docking from the Sydney University, but I'm not sure whether she is here. It's night for you, Kimberly, so, well, it's a poster about Don't Forget Us, clinical practice guidelines. Oh, you're there. Kimberly, are you there? No, I think Francois showed this.
Yeah, Kimberly is not there, so we're going to play pre-recording.
Oh, it's pre-recorded. Okay, then I can. You can send out the recording. Okay, I will mute myself and stop my video.
I'm proud to present new clinical practice guidelines for the management of communication and swallowing in children diagnosed with brain tumour or leukemia. Brain tumour and leukemia are the two most common cancers in children, making up to 60% of all cancers. The survival rates are increasing for these childhood cancers, but so are the incidence rates. Due to advances in the field of cancer, we have the privilege of supporting more and more children who now have their whole lives ahead of them, but who also have a high chance of experiencing communication and swallowing difficulties as a result of their cancer and cancer treatment. Up to 80% of children treated for brain tumour or leukemia can develop long-term communication problems from their cancer and life-saving treatments. Some children don't develop speech or communication problems until months or even years after their cancer treatment, but if left untreated, social and personal relationships, schooling and career prospects can be severely impacted. Many children also experience difficulties with eating and feeding during or after their cancer treatments. To address this problem, a large international team of stakeholders developed world-first clinical practice guidelines released in May. These guideline recommendations and practice points provide an equitable approach to the care of children surviving brain tumour and leukemia who are at risk of long-term communication and swallowing disorders. Development of recommendations was informed by three sources of evidence: a large-scale systematic review using grade certainty of evidence ratings, a panel of experts comprised of consumers and leading research and clinical experts worldwide who undertook the Grade Evidence to Decision Framework, which is a transparent framework for developing summaries of evidence and a systematic approach for making clinical practice recommendations. And thirdly, a health professional and consumer group survey. The guidelines are translated into 6 languages and hinge on 2 key recommendations, which were rated as strong recommendations: that both communication and swallowing assessment and intervention should be offered to children diagnosed with brain tumour or leukemia. Key practice points for assessment and intervention were developed based on survey outcomes, as well as multidisciplinary care, education and training. Regular comprehensive assessment and monitoring across phases in a world-first timing and setting framework ensures timely intervention is provided. The guideline underwent wide-scale international public consultation, including Australian government health departments, health, cancer and consumer organisations worldwide, as well as multiple rounds of scientific and independent review. The guideline recommendations are freely accessible to access and download via the NeuroKids website, where you will find all of the resources and translations. At the end of this year, we will be releasing multimedia educational resources for consumers and families in multiple languages. We are also releasing a health professional development training package in the coming months and monitoring impact and uptake of the recommendations by health professional and consumer implementation surveys. Thank you.
Thank you very much, Kimberly. I'm not sure whether you are on board now.
No, Kimberly, she didn't join, so she's not going to be in a position to answer the questions, unfortunately.
Okay. So I look now for questions. I think there are no questions in the live Q&A at the moment. So I think we need to continue with the third presentation. That's Ivan Flores from Canada, Colombia. Ivan, your talk will be about clinical practice guidelines role in drug funding decisions in Canada and Colombia. That's a very nice combination. Ivan, the floor is yours.
Thank you, Jacob. I'm sharing the screen. and you should be able to see it now. Good. Okay. Okay. So thank you very much for the opportunity for being here. And so our project was very interested in the idea of how our clinical practice guidelines used in different contexts. Specifically, how are they used for taking decision, making drug funding decision. We all know that in some contexts and countries, guidelines are used to inform drug funding decision coverage or reimbursement decisions. So we wanted to understand whether guidelines are used, how they are used, and under what condition they are used in decision about drug funding in two different contexts, a high-income country and a middle-income country with completely different healthcare systems. We designed a multiple case study. In Colombia, our case was focused on any drug funding decision, while in Canada was focused only on cancer drugs. It was more complex in Canada, so we decided to focus on the decision around cancer. To respond to our question about how we categorize the guidelines as uses as instrumental, conceptual, and symbolic. Instrumental is when the use is key for that decision. Conceptual is more about the terms, the concepts, and the symbolic is only to support some decision that we're taking. And also to respond under what condition, we use the 3I framework, which is in order to understand why do we think that happened. We apply an analytic technique of explanation, building to understand the factors that have influenced the use of guidelines in these two different contexts. In Canada, we focus on Ontario, to understand how the guideline process was done by Cancer Care Ontario and how this information was used to inform at the federal level by CADAT, which do HTA and inform drug funding decision. We interviewed 18 key informants. We found that in Colombia, the guidelines had an instrumental use. That means that it was used as an evidence source for prioritizing drugs and for drugs to be evaluated, was used as a conceptual use to inform drug reviews document. The document that supports the drug funding decision was informed by the guidelines. And the symbolic use is when the decision was taken about funding or not a drug, it was supported or what backup on what the guidelines used to recommend. In Canada, Ontario, we found that the government structure and the knowledge and beliefs about what people that take this decision think about guidelines could explain that there was no instrumental use, only conceptual and symbolic use. And symbolic, as I said before, is that decisions were taken against or in favor of a drug, and the documents reported that that decision was aligned with the guideline that recommended or not recommended that drug. While in Colombia, the situation was different. It was instrumental. It was something that guidelines were used to inform what drugs should be funded. Guidelines were the major source. Either the evidence was chosen or the recommendations were chosen to take the decision. So we have found many key differences in this. And in general was that in Colombia was instrumental, while in Canada was only conceptual and symbolic. And the symbolic was used in both cases to back up the final decisions that the drug funders need to take in both contexts to say that it was aligned or not with the final decision that they took. Thank you very much for your time. I'm happy to respond any questions.
Thank you very much, Ivan. At the moment, there are no questions, but I have a question to you that's the distinction between instrumental, conceptual, and symbolic use. What would you expect or prefer the kind of use of guidelines?
Okay, so instrumental, of course, it depends where you are, the healthcare system you are, and who is funding the guideline development. It's not the same about if it is done by a professional society, but rather than government-funded guideline. It depends on the healthcare system, of course. However, we know that guidelines are used for this kind of decision about what a drug to fund or not. We wanted to understand how it was used. I don't have any preference. It could be some context we need as an instrumental use. In some other contexts, guidelines could be used just to frame the question, to use to decide what would be the scope of the final HTA or the review to decide if the drug is going to be funded. So the preferences depends on the healthcare system, on the developers, and who is funding the guideline, and what the guideline is made for. What is the purpose of the guideline? There are many guidelines that are only focused on targeting clinical decision, but there are some guidelines in some countries, and that happened in Colombia, that there was an interest of the government in order to use guidelines to inform this kind of decisions, which was the final aim. That's why it ended up being instrumental. It was funded with that purpose, for the use for those decisions, which is not the case in Canada and other countries. We know there are other countries that had different cases in which they are used for more instrumental or conceptual, or even more symbolic, just to say that, yeah, we decided this. Can you see that the guideline said the same that we just decided, just as a backup?
Yeah, thank you, Ivan. Another question is, you know both countries, you know Canada and you know Colombia. That's your country where you was born. What could Canada learn from Colombia? What could Colombia learn from Canada?
You're making very challenging question, Jaco, today. So the situation that happened with guidelines in Colombia was there was a lot of funding from the government to do national guidelines. So I would say that Canada could learn from that experience about funding a national guideline program, which doesn't exist in Canada, except for some for the Canadian Task Force for Preventive Healthcare, which does guidelines that are focused in the whole country. The rest of the guideline process are focused on the provinces, and each province is autonomous in deciding what to do and what to do with the guidelines and protocols. So the national guideline process that we did and we are still doing at some point in Canada and Colombia is something that we could that could learn. And in the opposite side, the process of doing drug funding decisions is more robust in Canada, and in some cases maybe we don't need guidelines to inform those processes because the target is different, and not all the information and the target and the aim for doing a guideline is not necessarily the same. It doesn't have to be aligned fully with the drug funding process. We have different scope and different final aim. So I think that the process is a little bit more robust in Canada than in Colombia, but the guideline process and the national guideline program was more interesting in Colombia.
Thank you very much, Ivan. I think we can continue with the next speaker. That was a poster of Kelly Grieve from, USA. But she has been replaced by James Hedgecock. So welcome, James, and the floor is yours.
Great, thank you. I think I submitted a pre-recording, but I can also just give my talk, whatever is easier for the moderator.
James, is as you want. I can play the pre-recording. It's ready.
Okay, that would be great. Thank you.
Hello, my name is Jim Hedgecock, and I'm appreciative of the opportunity to present on behalf of the Guideline Development Group from the Academy of Pediatric Physical Therapy, creating a CPG to improve mobility for school-aged ambulatory youth with CP. Variability exists within PT intervention delivery for this population and is a widely recognized challenge in clinical practice. Per best practice for CPG development, we created and validated a web-based stakeholder survey to validate the need for a CPG and to focus our systematic review and synthesis efforts given the large amount of literature on this topic. The survey was distributed to over 15 clinical associations and relevant community advocacy organizations in a large research registry to gather a convenient sample of PTs working with ambulatory children with CP, adult caregivers of school-aged ambulatory youth with CP, and ambulatory adults with cerebral palsy who previously received physical therapy intervention as a child. Respondents rated the importance of inclusion in a CPG for 48 interventions, representing all domains of the International Classification of Functioning, Disability, and Health. Rating was completed using a 4-point Likert scale with an additional option to indicate unfamiliarity with an intervention. Survey responses were analyzed in a tiered approach, beginning with consideration of interventions that achieved greater than or equal to 90% rating of important or very important by PTs because clinicians are our primary end user group, and the limited relative number of responses from other stakeholder groups. We also examined agreement between the other stakeholder groups and physical therapists by considering the top 15 interventions ranked important or very important by adults with CP and caregivers of children with cerebral palsy. Our survey generated 299 responses, of which 85% were physical therapists, 11% were caregivers, and 4% were adults with CP. 18 interventions achieved greater than 90% important or very important rating amongst physical therapists, and each intervention had agreement with at least one other stakeholder group. 5 interventions achieved agreement amongst all 3 groups. Only 1 intervention achieved high priority ranking amongst caregivers and adults with CP that was not included in the PT high priority group. High priority PT interventions represented all domains of the ICF. Our team placed a high priority on inclusion of the perspectives of groups that may be impacted by the CPG. Unfortunately, we received significantly less responses from adults with CP and caregivers of children with CP compared to our primary end user group. This may have occurred based on our guideline group's connections with physical therapy organizations to achieve a higher advertisement rate, and because we involved community and advocacy organizations after the survey had already been developed. Involvement of these groups in survey development may have improved engagement. The results of our efforts may also contrast with typical clinical practice guideline stakeholder validation methods that are currently used, given our effort to include a larger sample of representation amongst our stakeholder groups. Incorporation of clinician, patient, and family views to determine CPG priorities was useful to focus systematic review and synthesis efforts and to aid usefulness in the CPG to the majority of people who may be impacted by its development.
Well, thank you, James, for this presentation. I'm looking for questions at the moment. No questions. My question, James, is how does this relate to guideline development?
Well, given our population and the wide variety of clinical practice options for interventions for this population, we felt it important to involve all potential people that would be impacted by this guideline and its implementation to help determine our research efforts and systematic review efforts. So as I'm sure all of you have probably experienced in development, we're in our nascent stages, and we came up with 48 possible interventions that our expert group believes there's some evidence to guide practice for, but to be able to write a CPG that encompasses the entirety of PT practice around this population is impossible to do in a timely manner. So we needed to focus our efforts to be able to provide the best evidence, and we wanted to do so for interventions that were high priority items for the people that would be impacted by the guideline.
Yeah, thank you. Surprisingly, there was a high degree of agreement among the different groups, particularly the consumer groups and the physical therapists, the professionals. I remember also research where there was a real disagreement, so that other priorities were given to interventions. Did you expect the agreement, or was it also for you surprising?
Yeah, our group was actually particularly surprised by the mix of interventions across ICF domains. So that's been another area of controversy in physical therapy practice for kids with CP. And we were definitely surprised that there was some level of agreement between consumer stakeholder groups and professionals, especially around the areas that were able to achieve agreement amongst all 3 groups.
Yeah, maybe that is due to the strong relationships between the professional and the patient. I'm not sure about how this is in the US, but if you know the patient and the patient know the professional, then they share their priorities. Could that
Correct.
be an explanation?
Yeah, I think, we think that potentially we were, one explanation for this that we were surprised by is how much integration of evidence from academic centers and places with a high priority on the ideal of the way rehab can be practiced with this group may have actually come down to the consumer group and influenced their opinions around PT intervention delivery.
No. Okay, thank you very much, James, for this presentation. And we can continue with the next speaker, which is Lindsay Howitt from which country? I'm not sure.
Thank you.
Canada, I think Canada, Lindsay.
Yes,
So,
from Canada. Thank you.
Yeah, from Ontario. So please, you can start.
Thank you. I also submitted a pre-recorded presentation. If it's possible to show that, that'd be great. And then I can answer any questions after. Thanks. Good afternoon. My name is Lindsay Howlett, and I'm a guideline development methodologist at the Registered Nurses Association of Ontario, also known as RNAO. RNAO's Best Practice Guidelines program was launched in 1999 with funding from the Government of Ontario, and to date, we have published 49 Best Practice Guidelines, commonly referred to as BPGs. At RNAO, we develop each BPG in collaboration with an expert panel. And since 2005, we've included persons with lived experience in our expert panels to ensure BPGs are reflective of persons' values, preferences, and needs. We use the term persons with lived experience to include patients or members of the public with firsthand experience of the topic of interest, caregivers, and advocates. In 2019, the RNAO's Person and Family Engagement Strategy Committee was convened to examine and strengthen existing processes for involving persons with lived experience. As part of a process evaluation, we conducted 8 semi-structured interviews with persons with lived experience to assess the acceptability of the guideline development process. We asked questions such as, what did you like most about your experience and what did you like least? Did you encounter any challenges sharing your views? And what kind of supports could RNAO provide to enhance collaboration? This slide shows some of the key findings that emerged from our interviews. Overall, persons with lived experience reported many benefits of participating in BPG development, including meeting other panel members, making a difference, and being part of a fun and engaging process that was organized, rigorous, and professional. However, they also noted that the process of interpreting the research evidence required a lot of work, and it would have been helpful to have additional resources to help them interpret the evidence. Some participants also faced challenges speaking up, and they stressed the importance of feeling empowered and comfortable to share their voices. They also described how power dynamics can exist in the panel, and to promote understanding and respect, they recommended that other panel members, such as health providers, be educated about the unique challenges that persons with lived experience can face when participating in guideline development. They also recommended facilitating opportunities for group bonding with other panel members. After reflecting on the feedback, several steps have been taken to enhance engagement. Our team has taken steps to widen access to a larger network of persons with lived experience that we can recruit. We've also taken steps to clearly describe the eligibility and selection criteria for persons with lived experience, as well as the role of panel members and the level of commitment required. Regular check-ins have been initiated to identify persons' unique needs.
Okay, thank you, Lindsay.
Thank you. I apologize there. I think the video may have gotten cut off shortly at the end, but I was wrapping up. As our committee continues with this work, we will integrate further strategies to ensure equity for persons with lived experience in guideline development.
Bonsoir.
And if you have any further questions, you're welcome to email me at lhowlett@rnao.ca.
So we did hear you another time. So Lindsay, thank you very much for your presentation. I'm looking for questions, and there was a question. I'm not sure whether this applies to your talk. How did the differences in structure in each country explain why the CPGs were used differently?
I believe that one may have been from a previous presentation, but I may be incorrect about that.
I'm not sure whether this applies to your presentation, but it was sent 1 second ago. Okay, well, my question is, I was a bit surprised about the term persons with lived experience. When I think about persons with lived experience, I think of patients, but that's not what you mean.
Yeah, so we use the term persons with lived experience at our organization to include patients or members of the public who have been impacted by the guideline topic. And one of the questions we actually asked when we did our needs assessment with these 8 people that we did qualitative interviews with was what would be your preferred way of being identified on the panel. And we had done an environmental scan from a variety of other organizations and guideline developers and found that there's quite a bit of variability. And so sometimes the term patient partner is used, or lay member, or there was quite a variety in the terms that were being used. So one of the questions we had asked was what was the preferred way of being identified, and we had provided a list of a few different terms that we had heard about and asked them also to suggest other terms as well. So this was one of the things that came out of the interviews was the term persons with lived experience was preferred over the term patients, with at least just with these 8 people that we had interviewed. And some of the feedback we had received was that with these specific people that we had interviewed, sometimes the term patient has a very medical terminology associated with it, and they identified in a different way. So that's sort of an overarching term we use at the organization. But of course, if somebody we were working with on the panel had a really different term they wanted to use, we would go with the term that they identified with.
Yeah. So you interviewed those persons. But I would also be interested, it's not part of your study, about professionals. How do they experience the patient involvement and patient engagement? Do you know something about that?
That's an excellent question as well. I think that might be step 2 of our exploration. I think one thing that we have been hoping to do is we did these 8 interviews, and we hope that the interviews, the findings from them are really going to help shape our strategy to continue to strengthen our processes for supporting persons with lived experience in the development of our guidelines. But as time goes on, we hope to interview more people to see if differences are being made, and so it will be an ongoing sort of evaluation, but maybe we could add in a piece about what you're talking about as well.
Well, my experience is that if professionals are a bit reluctant to talk with patient or patient representative, but when they are forced to do that, they like it. They are very inspired by patients, but it should not be one patient, it should be 2 or more. And the chair should also ask the patient to really contribute, and then professionals can be really, well, surprised about their input, and then there's a dialogue. So there's also research on that, and well, you cannot make guidelines without patients in your group. So that's one of the conclusions. But well, it's interesting that you ask them about their experience, retrospective, and we can learn on that. This is still part of the guideline approach at your organization in Canada. Am I true?
Yeah. Yes, it is.
Yeah, okay, thank you very much. Okay, I think we're done with this, or do we have still some questions? I see a question. Sorry. Do you have structured induction and support for people with lived experience? The question from Erin Whittingham.
Thank you for that question. So one of the things that came out of our interviews was that we could be providing additional support, especially with interpreting the research methodology, research terminology, and the grade process as well. So that's something that we are currently sort of working on to help strengthen that approach. There was a few suggestions that kind of came out of that as well, of having cheat sheets or additional educational materials and whatnot that are available. But right now at the beginning, when we gather a panel together, we do a structured orientation for all expert panel members, which includes persons with lived experience. And we also have some orientation videos that we send out as well. And then with persons with lived experience, but also to anybody who's on the expert panel, we try to intentionally check in with people and ask if there are additional learning needs as well, and if we can meet with them to support them in any additional ways, sort of on a one-on-one basis as well. So that's our current process, but we are looking for ways of how we can continue to strengthen it as well. Thank you.
Yeah, thank you. Still one question, last question from Trudy Beckering from Belgium. Can you share an example where patients made a difference?
So I think in a lot of different ways, having patients part of an expert panel that's helping develop a guideline they can contribute in many different ways, even from the very beginning in helping shape the scope of a guideline, from sharing about what outcomes really matter to persons with lived experience, all the way through to sort of when the recommendations are being voted on and whatnot. So helping to inform things to do with values and preferences, whatnot. So I think all throughout the process, there's a ton of valuable input that can be offered.
Yeah. Thank you very much, Lindsay. Then we can continue to the next presentation. That's a presentation by, I do not know your forename, Scott. Strategies for Involving Patients. Sarah, thank you. Hi, hello, Sarah. Strategies for involving patients and the public in living guideline development panels during the pandemic. Well, the floor is yours, Sarah.
Okay, thank you. Let me just share my screen and get the presentation up. And zoom in. Okay, hopefully you can all see that. Okay, yeah, thank you. So yes, so just a little bit of background. I'm Sarah. I'm currently a public involvement advisor at the National Institute for Health and Care Excellence, NICE in England, and I sort of led this evaluation looking at kind of what worked or what didn't work, and how did patients for patient and public involvement in living guidelines or rapid living guidelines. A little bit of background to this is that so we were asked to produce COVID guidelines during the pandemic, and we had to do it pretty quickly, so there's a rapid nature, and we adopted sort of a living guidelines model. So we were having to produce guidelines sometimes in the space of a month. So we wanted to involve patients in the public like we normally do in our standard guidelines, but because of the speed at which we're having to develop, we were successful involving people in the panels, but it did mean that we had to sort of we had to sort of adapt our patient and public involvement strategies. Some of the things we weren't able to do, such as providing training. So we wanted to evaluate what we did do and whether it worked. So we did some focus groups, and we invited the lay members, we call them lay members at NICE, patient and public members. We invited the lay members to focus groups, and we also did a separate focus group with staff, the staff and the chairs involved with working with the patient and public members. We wanted to really ask questions around out of all the strategies we used, what worked, what helped them to have impact, and what kind of impact, what did that look like, and how would they want to be supported ongoing, in living guidelines when you've got something, maybe, it could be a couple of months down the line, there'd be new evidence, so they'd have to come back again potentially. So how would they want to be involved? We had the 9 lay members out of 10 turn up and 5 out of 7 staff and chairs. So overall, we found, in terms of impact, we found that lay members did have impact on the guidelines, although they felt that they did, particularly around influencing recommendations. And the table there shows the different levels of impact and different places where they felt that they had impact in the guideline development. But what was really interesting is there was a bit of a discrepancy between what the staff and chairs thought the lay members actually did, in that the staff and chairs thought that the lay members had more impact than what the lay members themselves thought they had. So that kind of showed us that they needed to have better feedback about their involvement and what was working, what wasn't working. And that was something that was shared amongst everybody. Everybody felt that they wanted more feedback about their involvement and how well they were doing. It also came out that it was really important to involve people in the scope, because some of the guidelines were very technical, very medical, very clinical, and sometimes lay members felt that they didn't know how to have impact because perhaps the scope wasn't so patient focused, or focused on experience. So there was this kind of idea that people, all staff and chairs and the lay members, wanted to understand a lot better about how to get the patient voice heard. So there was talk and suggestions about involving people in the scope, but also potentially using testimony where people can write or present their experience within meetings, and that could then be taken into consideration. Interestingly, when we asked about what worked out of all the public involvement, we presented a list of around 20 public involvement strategies that we used or could have used. And interestingly, the staff and chairs and the lay members all talked about the same 8 strategies, which suggested there was some kind of importance to the sorts of all the different types of public involvement strategies that we could have used. So, for example, everybody really emphasised the role of the chair and their ability to guide the discussion and encourage the lay members to contribute. The table in here also shows quite some other aspects there around strategy, such as having pre-meets and a named contact for someone to talk to if they've got any issues. We also looked at barriers to impact, and one of the key things there was, even though some people felt that they did know that they had impact, a few people weren't sure how it made a difference. And one of the key barriers was the medical jargon, and even to the point that one of the chairs felt that they were a bit intimidated by the amount of jargon. And it was sort of an agreement that the fact that the meetings were taking place virtually was actually contributing to that barrier, because usually in a face-to-face meeting, during the breaks, lay members might be able to talk to the technical staff and ask questions. What did that mean? What did that mean? Where this wasn't happening in the virtual setting. So there were some challenges there that we learned about. And of course, the short time that people were given to read so much information. And actually, one of the things we found was that the lay members felt that there was far more work to be done between meetings via email compared to normal standard guidelines. So that was something that needed to be taken into consideration. Ultimately, what we found was that all the strategies that you would use for good patient and public involvement in guidelines, all the strategies that you would normally use for standard guidelines are actually applied to living guidelines. So that means that the lessons that we've learned here can actually transfer onto sort of standard living guidelines, which aren't so rapid. So our next steps, really, because a few barriers did occur, there's clearly some challenges to doing living guidelines and involving patients and the public. We're going to do a workshop where we invite all the participants, including the staff and the chairs and the lay members, to come along and start co-creating solutions about how we should do this and how do we overcome the barriers, but bearing in mind resources and keeping a realistic perspective. So thank you. Any questions?
Thank you very much, Sarah. That is very interesting. I like this kind of qualitative research. In addition to quantitative surveys, which also has been presented. To be clear, in the tables you mentioned the absolute numbers, but you interviewed 9 lay members and 5 staff chairs. So that also explains the lower numbers in the tables, because you interviewed less staff chairs than lay members. Is that correct? Yeah.
That's right. Yeah.
Yeah. Okay. I look for questions in the Q&A. Not seeing yet, but I have a question. Also heard in the plenaries, NICE is developing so many guidelines, so many recommendations. How did you deal with the COVID-19 pandemic? You organize online conferences. I guess, but how did it influence the consumer involvement?
What in terms of the sort of the rapid nature of developing the guidelines? Is that,
yeah, across your whole program, not only on the COVID-19 guidelines, but for your whole programs, what's the effect of the COVID-19 pandemic when you organize online meetings about consumer involvement? Maybe in some aspect it improved, but in other aspects it was more difficult. So what are your experience on that?
Yeah, the online version. Yeah. So I think one of my colleagues might be presenting on this tomorrow. So yeah, I think we found mixed. It did help a lot of people. A lot of people felt that they were able to attend meetings that they wouldn't normally be able to. So that was one of the advantages. Some people, I think the lack of connection with others, that was a big thing. And like we said, we found in the evaluation for the living guidelines was that people are unable to connect and share, ask questions, and the relationship element is something that sort of suffers. So, you know, we've been trying to talk about, can we create another, albeit virtual, space for people to have conversations and meet up. And we have been trying to think about doing like group inductions. So when we do our inductions with public patient and public members, trying to create a group environment, and that was something that actually came out of the focus groups as being something people really valued, and peer support was absolutely important. So we did try to adapt, and particularly with the COVID guidelines, we tried to include people who had experience of guidelines as well as people who didn't, so they had that ability to sort of have a conversation if they were stuck, or get ideas about how to be involved and how to make an impact. So yeah, there was lots of different things like that, and fatigue was another thing. So managing fatigue and having to have more breaks, that was something else that we considered.
So I think you will also keep the things that you've learned from the COVID-19 pandemic. My second question is, it's a very big country. In the Netherlands, we are small, so we can quite easily organize physical meetings. But now you are forced to do it online. And could you involve the patients from remote areas more in Great Britain, UK, in guidelines, because of the size of your country?
Yeah, definitely. I think that was definitely one of the benefits. From what we were aware of, at least, when people told us, you know, people would often come forward and say, I can take part now. I wouldn't have been able to before because of where I live, because I'm at the corner of the UK. So yeah, there was definitely a benefit as a result of that.
Okay. So there are pros and cons because of the pandemic, but we can also benefit from other things. Okay, thank you very much, Sarah, for this presentation. Then we continue to the next one. That's a presentation of Gandana Gua from the University of Sydney. It's from Australia, and it's in the night in Australia. So I'm not sure whether she joined us. François, do you know whether she joined?
We now have a presentation from David Tunnicliffe, who is not with us.
Okay. Oh, David Tunnicliffe. Oh, and I see it's in bold, yes. But he's not there. That was a presentation on, yes, that's this one, developing guidelines by consumers for consumers. Very interesting, by the way. It's very innovative and unusual. But, well,
hi, my name is David Tunnicliffe. I'm the research fellow at the University of Sydney and the CARI the Guidelines Scientific Director. Guidelines have traditionally been written by clinicians for clinicians. However, increasingly, guidelines are incorporating and involving consumers in this work. Some of the work that we have done is producing content that is led by consumers for consumers. And CARI Guidelines is the Australian and New Zealand guideline developers in kidney disease. And we'll use an example from two of our guidelines, renal biopsy guidelines, and also a transplant evidence summary for COVID-19. So how do we do this? Well, we identified consumer priorities, running workshops that identified topics that were used to expand the guidelines scope, the clinical practice guideline. We identified how consumer content should be produced and what was the focus should be using focus groups. And we produced consumer content summaries and infographics. We had a network of consumers in our renal biopsy. This was led by two volunteer members of CARI Guidelines, both consumers with lived experience. And then for the COVID-19 transplant summary, we had over 10 consumers involved in a focus group, and also the addition of a clinical, a clinician with expertise in the management of transplantation. The renal biopsy had 17 patients in the workshop, and there was no set timeline, no deadline, and volunteer members. So this was produced in 11 months. However, those learnings were taken into the transplant evidence summary for COVID-19, and where we had focus groups, and the summaries and infographics were produced in a matter of 2 weeks. What we were able to produce was something like this. These are the examples of the infographics, something that are based upon the findings of the clinical practice guidelines, covering all the scope of in kidney biopsy, from what is a kidney biopsy to what are the medications we should use, what is the procedure, what should happen at post-care as well. And this is available on our website and also being distributed to patients via clinics. Then finally, also over on the right, we have the COVID-19 example of an infographic about how to manage COVID-19. This was quite early on in the global pandemic in March and May 2020. Thank you for taking the time to listen to me, and please contact me via email if you'd like any more information. Thank you.
Thank you very much, David from Sydney. I think you have a good night at the moment, and you are not here. I can understand that. So I think we can continue with the next presentation. By the way, I've seen now 3 questions about the talk of Sarah, and I would suggest that to ask these questions at the end of all presentations. So we can continue now with the presentation of, I think François Yun Wang was not there, eh? François?
Absolutely, so it's going to be Anna now. Yeah,
okay, that's from China, exploration of how developers use qualitative evidence. You can look at the poster. Thank you. Then the next one is Ana Niño de Guzman from Spain. I hope I pronounced it well.
Hello, yes, very good.
Okay, thank you very much. I think you can start now.
I have a pre-recording session. I would like to present that, please. This study was conducted in the context of COMPARE-U that aims to identify the most effective self-management interventions for patients with diabetes mellitus. In the process of making recommendations, it's important to incorporate the perspective of patients on the importance of outcomes. One method to measure this is the use of utilities or disutilities. Utilities represents preferences patients exhibit for a particular outcome, and is measured in a scale that goes from 0, representing death, to 1, that represents perfect health. And it is utilities that are reported as the decrement in utility due to a particular health state, and is expressed as a negative value. We aim to review and summarize all available evidence exploring how patients with diabetes mellitus value the importance of outcomes. We identify systematic reviews of studies assessing how patients value outcomes importance, reporting utilities or disutilities obtained using direct or indirect methods. We search in 3 databases, until December 2020, apply the Johanna Briggs Institute critical appraisal checklist. We estimate the corrected covered area to measure the overlapping of primary studies. We estimate the general statistics, the general descriptive statistics, and conduct a de novo meta-analysis for outcomes with more than one observation. We identify 11 studies, systematic reviews, representing 152 primary studies reporting utilities or disutilities for 61 outcomes that were categorized in 7 categories. 6 systematic reviews included studies from worldwide, and also 6 assessed the quality of included studies. The most common used method to obtain utilities was the EQ5D. The categories with the lowest mean utilities were diabetes, non-specified diabetes complications, microvascular complications, and comorbidities. And the 5 outcomes with the highest impact in descending order were having 2 or more non-specified complications with 0.43, followed by diabetic peripheral neuropathic pain with 0.46, amputation with 0.53, end-stage renal disease with 0.55, and extreme obesity in comorbidities. In comparison, the best value outcomes were having good or excellent glucose control. We aim to provide a set of utilities and disutility values informing how patients value the importance of outcomes in diabetes mellitus. With this information, we could guide the decision-making process regarding diabetes healthcare at different organizational levels. Thank you very much.
Okay, thank you, Ina, about this presentation. I hope that people could read it because it was a bit small, but the presentation was clear. I'm looking for the questions. No questions about your presentation. I have one question, Ina. So the chosen outcomes, maybe there's also variation among patients. That's better. Yeah.
Yeah. Sorry, because I realized that in the pre-recording it was so small. So now yes, you can see here.
Could you scroll down to your conclusion? Yeah.
Yes, of course.
And my question is that if you group the outcomes and the preferred outcomes together, then you conclude with the data you presented in the table. But I can also imagine that the outcomes will differ for each patient. So could you also, what do you think about more individualized outcomes?
Yeah. Actually, the idea with this work was trying to find evidence reporting studies that measure how patients value outcomes and also reporting the variability. So here we presented the pooled data, the mean pool, and also the confidence intervals. So here in the confidence intervals, we present the variability. So there is some that are very not so wide margins, but others that present, for example, wider, that can come from, for example, here in heart failure, goes from 0.3 to 0.48. So you can see there is a wide variability here. So it's also reported here in the I-square. We have a 97% of heterogeneity. So yes, we identified, we reflect here in numbers what is actually found in reality. We have a wide variability, but still when we need to make a decision trying to to balance or to identify which is the most value outcome or which is the outcome that has a higher impact in patients' life. Well, these numbers help to decide, to make a decision. That's was our objective.
Yeah. Okay. Thank you, Ina, for your answer. I think there are no additional questions, so we continue with the next presentation. That's from Oksana Gulenko, or I think it's from Evgenia Rubtsova from Ukraine. And I hope she is here because she has the two presentations.
Yeah, and we're going to play two pre-recording for her because she's not here.
Two pre-recordings, but Evgenia is not here, but we can still listen to the pre-recordings. You can start the video.
Hello, I represent the State Expert Center of the Ministry of Health of Ukraine and our poster interdisciplinary approach to mental and behavioral disorders due to opioid use. It's estimated 247 million people worldwide use drugs, of which 29 million suffer from substance use disorders, and only 1 in 6 gets access to medical care. Today, the issue of use and dependence on opioids in Ukraine is extremely acute due to the widespread prevalence of HIV, AIDS, tuberculosis, viral hepatitis, and other infections among injecting drug users. Joint efforts of the Center for Public Health, the State Expert Center of the Ministry of Health, the Ukrainian Institute of Public Health Policy, began work on the development of documents on the medical care standardization for patients with behavioral disorders due to opioid use. During this work, multidisciplinary working group analysis of international experience and the existing legal framework was conducted. Sources of evidence were searched in international recommendation, NICE, WHO, EPA, and other. A medical care standard for patients with mental and behavioral disorders due to opioid use has been created and approved by the Ministry of Health. This standard provides an integrated approach with the involvement of various specialists, medical workers, psychologists, social workers. The goals of treatment are to reduce the use of substance as well as to prevent or further transmission of bloodborne infection. Considerable attention has been paid to screening opioid users. The screening is routinely performed by family physician for all adults who seek help at least once a year. Along with medical treatment, patients are provided with psychologist support. The development of the standard is a significant step in providing medical care to patients with disorders due to opioid use. This issue at the state level will allow to implement better approach to the provision of services at all stages of diagnosis and treatment, and to minimize the negative consequences for the health of drug-addicted persons and society as a whole. Thank you for the attention. See you again. Hello, I'm Evgenia Rubtsova from the State Expert Center of the Ministry of Health of Ukraine, and I would like to present our poster, Organization of Rehabilitation for Patients with COVID-19, in Ukraine. Patients with COVID-19 are in the dire need of rehabilitation during their hospital stay and after discharge. On December 2020, the law of Ukraine on rehabilitation in the healthcare sector came into force, which provided the legal basis for the introduction of modern approach to rehabilitation care for patients with COVID-19. Based on the recommendation of WHO, NICE, NIH, and other relevant international organizations, the multidisciplinary working group has developed a new format of clinical guidelines, the so-called LIVE guidelines, which is regularly updated and supplemented with new evidence, taking into account the current evidence and the current legal framework of the clinical protocol for the providing of rehabilitation care to patients with COVID-19 in convalescence that was created and approved by the Ministry of Health of Ukraine. Clinical protocol of rehabilitation care for patients with COVID-19 contains our following: algorithms for providing rehabilitation care to patients, methods of physiotherapy and occupational therapy, patient and rehabilitation specialist safety issues, selection of tools for assessing the rehabilitation needs of patients with COVID-19 based on international classification of functioning, disabilities, and health, organization of rehabilitation care in acute, post-acute, and long-term periods. So, the availability of such modern medical documents is a step forward in the field of rehabilitation care. For the implementation of the provisions of the protocol, will help to coordinate the actions of medical staff at all levels of medical care, as well as allow to restore the health and efficiency of individuals as soon as possible after COVID-19. Thank you for the attention, and see you again.
Thank you. Two presentations from Ukraine, and I think it's very interesting to notice that Ukraine faces the same problems as in other countries. First of all, about the opioids crisis, which includes maybe some different drugs, but also very addictive drugs, and the way they coped with the COVID-19 crisis. I think it's very welcome that they also used the WHO and NICE and other guidelines. And I'm very happy to see that the rehabilitation for patients went well, informed by evidence-based guidelines. Thank you very much, Evgenia, for your presentations. There were no questions on these two presentations, so I think we can continue with Erin Whittingham from NICE about involving people living with cognitive impairment or difficulties. That's really challenging, how to involve them in guideline development. So, Erin, we're looking forward to your presentation.
Sorry about that. So yeah, I'm going to talk a bit about some work we did. It was a project about involving people who have cognitive impairment or cognitive difficulties. And the reason we were doing this was in 2007, we produced a resource toolkit for our staff about involving people with dementia. And a lot of people think, whoa, you can't involve people with dementia. They're unable to be involved in guidance development. And that's not true. Some people are. But what we found with that resource was What about other people that have the same kind of symptoms that some people have with dementia, so cognitive impairment? What about those? So what we decided to do was to look at doing a resource for people who have cognitive impairment from whatever cause. And, you know, some of you will know that stroke is one of the biggest causes of cognitive impairment. People who have chemotherapy for cancer, they can get cognitive difficulties. And what we decided to do was we would bring a group of people together and sit together for a 3-hour workshop and discuss what would it be useful for us to do at NICE to be able to involve people with cognitive impairments in guidance development. So we're talking about people sitting on committees and people involved in the wider development cycle. So the way we decided to do this was to use the co-production model. So basically I facilitated and we recruited 6 people from our patient and public involvement expert panel to sit with me for 3 hours. We did have breaks, many breaks, to discuss what they think they needed as a group of people with cognitive impairment in order to be able to effectively be included on committees, and for us it's nice to be able to utilize their expertise and their experience, because if you think about the amount of people who have cognitive difficulties, then you will realize that actually a lot of the population we're writing guidance for involves people with cognitive impairment, and we don't want to write guidelines for people, we want to write guidelines with people. So the co-production model that we used, the key conclusion from using that model was it gave us a richer data, it gave us richer content that we could put into this toolkit for staff. And the group was very, very keen to have some guiding principles. I will make it bigger for you for the guiding principles. So it's about involving people, and that they have to be involved in order to make the products relevant and real for people. And it's about thinking of people with cognitive difficulties, that they have all sorts of different issues and difficulties, but what does it take for them to live generally in life? The resources that they use in order to be able to have a quality of life is what we want in guidance development, problem solving skills, the ability to think differently and out of the box, to think about whether, you know, how they organize their time, the way they list things, the way they manage their cognitive processes, is very akin to what we do in guidance development. So they're perfect to be involved in this, but we have to make some differences, some changes in order for people to be involved. And I'd just like to go through the top tips just to finish. It's taking care of the language you use. People live with a condition, they are not the condition. And all decisions need to be made in partnership with people, with the person, and to think about them as a whole. So they might have other conditions, so sight impairment, hearing impairment. We need to think of people as a whole when involving them in guidance development. We need to keep key messages clear and concise, and ask one question at a time and give space for an answer. We could allocate, say, key buddies, and obviously we want to avoid using jargon. And one of the key things which 2 other presenters have talked about today is the importance of the chair. So the chair needs to be engaged and aware of the needs of the people in the room. And we need to make sure that people know what people's needs are, but on a need-to-know basis. So the key conclusion is that, yes, you can involve people who have cognitive impairment, in guidance development and the whole cycle of guidance development. But what you need to do is make some reasonable adjustments in order to involve people. Thank you.
Thank you very much, Erin. This is very interesting. We have a few questions. The first is from Sandra Kaplan. I'm looking for this. Had all of the consumers had prior experience with traditional CPGs versus this living guideline? I'm not sure whether this applies to your presentation. Sorry.
No, but I can answer that question with this.
Okay,
I think if it was about Sarah's, then I think she said in hers it was about half and half, and that's the same for mine as well. Half the people involved in the project had involvement in guidance development before, and half hadn't, and that was really important to get the richness of people who understand the process, but then people who don't, and then get to ask questions, which really gave us rich data in a qualitative sense.
Yeah, okay. Question from my side is the recommendations or the top tips also apply for people without a cognitive impairment.
Yeah, absolutely. And this is what we find when we write specific guidance, specific staff resources about how to involve people. We find that some of the specifics that small groups of people would like actually benefits the whole. And we find that the more we do this, the more we find out what people need in general. Obviously, for example, avoiding jargon. But what it does is it gives, when we do a toolkit, it gives staff confidence to be able to involve people who have things the conditions that people might go, whoa, we can't involve people with that's not doable, when it is doable. And point of doing the toolkits and doing some of the work we do at NICE is about empowering the staff, while we also in our department empower the patients. So we have to work as a whole team in guidance development. I think that's really important.
Yeah, and does this also include the partner of the patient?
Yeah, often the partners, yeah, and the people that care for them. Obviously, some of our people that have cognitive impairment might have a carer that comes with them. They might have a note taker. So we have to think about and ask them what are their needs. So sometimes people have, in the UK, we call them supporters or personal assistants, who help people who have a disability to be able to give their most effective involvement within guidance development.
Yeah. Okay. Thank you very much, Erin.
Thank you.
Yeah, we have a few minutes left, and I looked at the Q&A and I missed some questions. Maybe they came after the presentations, but we can still address these questions. First, a question of you, Erin, to Trudy. Yes, that was the question about what age of pupils did this cover? In the UK, we have schools for 4 to 11 years old, and then senior schools for 11 years plus. So to what kind of schools does the study apply?
Our study is incorporating both the primary and the secondary schools. So from 6 to 18, the pupils who were in our guideline panel were, I think, 14 and 15 years of age. Yeah.
Okay, thank you. That clarifies. Another question of Emily Vella for the presentation of Ivan. And we already talked about this, but I would also give her question a bit of time. her question is, how did the differences in structure in each country, Canada or Colombia, explain why the clinical practice guidelines were used differently? Ivan.
Hi, thank you, Jacob. So I went through.
You can turn on the video.
Oh, sorry.
And we can see you. Yeah.
So I went through all these, some of these concepts while in my conference, but I will come back to some of them. The first difference between the country, in addition to being of high income versus middle income, is that in Canada things happen. It's a healthcare, complex healthcare system in which there is federal and provincial level, and between two levels. So that are different from Colombia, which is a national centralized healthcare system in which you can do any protocol or guideline or whatever you can do at the national level, and it will be implemented in the whole country. So that's the thing different. And the reasons why how can I say, how was the use between the two countries is Colombia has an interesting guideline process in which was a lot of funding for the national guideline program, which doesn't exist in Canada. A national guideline program is something that it is a mix between societies and provincial governments. So that is a key difference. We had a national guideline program that was funded by the ministry, and the aim was to use those guidelines not only to inform clinical care decision, but also to inform drug funding decision, because the healthcare system was in a financial critical situation. And there was an interest in using guidelines and health technology assessment, both in order to help as a cost, to help to take decision and also as a cost containment tool. So that was the reason why they were instrumental in a lot of decisions to decide which drugs to fund, which drugs not to fund, which was not the case for Canada, of course, that because of the healthcare system and because there was a national guideline program and they were not created to do that, that's why they are not too much used in the provincial decision for drug funding decisions.
Okay, thank you, Ivan, for the answer. I have a few questions left on the presentation of Sarah Straat from NICE. So Sarah, are you still here? Yeah. Hi, hello.
Hi.
Yeah. One question you already answered in the Q&A, the question of Trudy about a clinician with a health problem as a patient in the panel. So that's with double heads. And you already answered that question in the Q&A. But there are, yeah, okay.
Yeah, I was just going to say, I think Erin answered that for me, so thank you.
Okay, but there are two other questions left. The first was the same question that already was answered by your colleague about have all the consumers had prior experience with traditional guidelines versus this living guideline, and if not, did they have different perspective on the process?
So I think, did they have a different perspective? So we involve, I suppose the answer applies to both standard guidelines and living guidelines, in that we can involve people with prior experience of the development process, as well as people without. In terms of whether it influences their kind of input, I'm not actually sure. That might be a good study to do, the comparisons. But I think what we do try to do, although we didn't quite do it so well in living guidelines because we didn't have the time, is that's offer training. So everybody coming in should have the same level of training. So that shouldn't make too much of a difference.
No. Okay, thank you, Sarah. And the last question for the last minute is from Amy Bird. You mentioned that there was more work in between meetings via email, etc. How can we best support lay members when communicating via email and ensure it is not burdensome? all the emails.
Yes. So I think there's two things that spring to mind that we're trying to do. So the first thing is to better use a collaborative platform rather than relying on email. So that was originally Magic App, which I think we're still to evaluate how that's worked. So that's where people can comment on documents and supposed to be able to have a conversation. There was talk about using MS Teams. That was something that one of the lay members really wanted to use, but we've had issues with different people not being able to have access and all this sort of stuff. So looking into a collaborative platform where everything's all in one place and people can comment, but at the same time, the other thing that we're looking at is when it is required to get the input from the committee members, particularly for the lay members, is to specify exactly what we need the input on, because otherwise they're tempted to read absolutely everything when that might not have been necessary. So we're trying to sort of signpost and kind of say this one document here is what we want your comments on, or something like that. And I think the final approach is that we are actually looking at a process for living guidelines overall, where if it's a definite kind of like decision, like the evidence is absolutely clear that the recommendation needs to go in one way or the other, there's a quick sort of summary that goes out to the whole committee, and then it's just a sort of a survey where people can say yes or no whether they agree with the direction that the recommendation needs to go in. So we're looking at ways of speeding it up, basically.
Okay, thank you very much, Sarah. We come to the end of this session. It's now, in the Netherlands, it's 8 o'clock. In Britain, it's 7 o'clock. In US, it's, well, I think in the afternoon. So I wish you a very nice day, a nice evening. Thank you very much for these very rich and variation of presentations on guidelines with and for users. And I hope you will have enjoyed it, and see you tomorrow or the day after tomorrow at further sessions. Bye-bye.
Bye-bye.
Thank you. Bye-bye.
Thank you.